This is Luis Areiza. Do you have any preference talking about the first valve? In this valve is really important. So what's happening in young patients undergoing TAVI? What do you prefer in in a standard anatomy? Do you prefer first balloon expandable, trying to get easy coronary access, or do you prefer self-expandable with a commissural alignment? What do you prefer for in this valve in your patients?
Yeah, we use a customized approach. There's no, one valve that fits all. Every one of the valves have its own benefits and drawbacks. I would say the first most is to make sure your first valve is optimally expanded. So for example, now routinely with the short balloon expandable valve, we do what we call double tap technique, where we actually post-dilate, not necessarily add volume because you don't want a root rupture, but also actually just the same volume, you can see that the valve expands under fluoroscopy further. Because what we see now is that a lot of times, some patients come back with paravalvular leak because the valve was sized appropriately. But there seems to be recoil, or maybe the calcium of the leaflets are getting a lot, so the valve now recoil and lead to PVL, and we have to post-dilate them again, or even put a second valve in to increase the radial force. We also care about gradient hemodynamics, and as you know, there are several valves that have single-digit gradients, both supraannular and intraannular self-expanding valves. So I think that's important, particularly for patients with PPM, because we know that patients with PPM don't do well, and with severe PPM has been shown to affect outcomes, especially in the context of the SMART trial. So I think that's very important to make sure the optimal valve can be done, can be selected the first time. Now, in terms of the lifetime management, you have to discuss the patient. That's why this simulation exercise is important. So for example, even with a short valve, if you're going to implant high, and you're going to seal off the sinotubular junction, redo TAVI is going to be difficult. You're going to have to put the second valve in, and you're going to have to use another short valve, but put it deeper, and that can impact on your hemodynamics. We've done that actually a few times now recently, because you cannot use a tall valve as a second valve, and you cannot put the second valve higher with the short valve, so you have no choice but put it actually deeper to allow some leaflet overhang to help with the coronary perfusion. So I think you have to take that into account in terms of when you do your index TAVI CT to look at what valve will be optimal for the patient for the first valve, how to optimize it during the first procedure. And if the valve that you choose cannot be doable with a second valve in the future, you need to let the patient know, so that at least for now we don't have a solution for you. Maybe in the future you do, but they should be aware, rather than just saying, oh, don't worry, we can put a second valve in the future, because that sometimes is not possible.
Thank you so much. We are always worried about overhanging in TAVI, and also worry about coronary protection. Are you doing any specific or something new trying to avoid coronary obstruction or overhanging in this kind of patients?
Well, I think if you do a redo TAVR, if you worry about coronary obstruction, you definitely want to protect. There's no question about that. In fact, it's actually a very nice landmark for you to see, where the top of the valve needs to land. When you inject an angiogram, you have the coronary wire in the left vein. You know that don't go above that wire, or even stay below that wire, and you do a very slow inflation. So that's very important to be able to visualize that. So yes, we do that quite routinely if we're concerned about the coronary obstruction. The other thing remember also is that the valve, let's say where you want to land, may not be actually where you end up. So to give you an example, we've done recently a number of the balloon expandable valve inside a failed balloon expandable or self-expanding valve. And what we found is that, the second valve rise up as you inflate, particularly if you, don't do a slow inflation. And so you have to adjust that very, to anticipate that. And so that you might have to use the wire to control it, You might have to be the first operator, which may not have a much control because now that you're against the frame to frame, it might not move as easily. So you have to account for that. And if the valve rise up, if you don't have coronary protection and the coronary obstruction happens, you're going to be in deep trouble. So yes, we do frequently protect, especially for TAV and TAV, because going back in afterwards with two valves, it could be very difficult. So we want to do it ahead of time.
Dr. Tang, this is Jorge Chavarria. I'm one of the interventional cardiologists here also in Central America. In our region, we have a high incidence of bicuspid aortic valves, more than reported in Europe and North America. Do you have any opinion in terms of this first valve and lifetime management in these patients, based on the possibility of redo TAVR, or based on the difference in the anatomy of these patients? And thanks.
Yeah, no, bicuspid, the good thing about bicuspid valve, when you've seen the anatomy as well, is that it tends to be larger than tri-leaflet valve. So there's a paper that will hopefully be coming out soon that talks about that in terms of reduced TAVR feasibility. And in general, bicuspid valve tend to be more favorable because the anatomy is bigger, and so you don't have to worry about the obstruction as much. Having said that, we just don't know the durability of bicuspid valves long term. With TAVR, we have some registries and low risk, but we haven't seen more than 2 years results or 3 years results. So we need to follow up with that longer term. One thing I have seen though, doing post-TAVR CT, is that some of these valves are not truly circular, and they might be underexpanded, and I'm worried that might be predispose these patients to halt and early degeneration. So I think for bicuspid valves anatomy, if you can make sure the valve frame can be optimized as much as possible, that will be ideal. We sometimes don't oversize much, especially for the balloon expandable valve, even sometimes self-expanding valve, to be able to really make sure the valve frame is fully expanded rather than compressed or worse yet, under expansion and infolding. So we want to make sure that doesn't happen.
Thank you so much, Dr. Tang. So much.
All right. Take care. Thank you for having me. Bye-bye.
It was a pleasure.